Just about everyone here. Still a few others probably yet to join us. And give it another minute.
Okay.
Good afternoon.
Hi, that sounds like Kimberly. How are you, Kimberly?
It is. I am good. I'm really good.
Good, good. Glad you could join us.
Thank you.
And Jeff, just to let you know, I'm looking at the participants. I'm also seeing that Sean and JJ are here. I don't know if Tom Siltebo has arrived yet, but I think it's your call whether you want to give it another minute or just go ahead and get started with the agenda.
I think we can go ahead because we have all the members here, right?
Yes, voting members, yes.
So with that said, I will call to order the May 18th, 2021 meeting of the Innovation Workgroup. And first order of on the agenda, first order of business, I should say, is approval of the meeting minutes from March 16th. Anybody have any comments on those?
Nope.
If not, motion to accept.
So moved.
Sounds like Sean.
Yep.
Thank you. Second.
I'll second.
Thanks. And so it seems like we have no other recourse but to approve them. So I will consider that approved. Okay, first thing up is the Lodestar RFI report.
Yeah, and so just to introduce this topic for today, as the work group recalls, we went ahead and released a Lodestar RFI late last year, received a number of responses. I believe the final was 17, and the Mercer team has been hard at work reviewing those and consolidating those responses into sort of an overall summary, which they're going to present today. So I will hand this over to James and Emery and whoever else on your team is leading. And just sort of a logistics question here. Do you guys want to project the slides on your end, or do you want us to do that? What works best for you?
I think we're fine just saying next slide if that is amenable.
Sure. And Rose, do you want to go ahead and do that, or would you like me to take control?
No, that's fine. I can do it, Margaret.
Okay, great. Thank you.
Okay, I will start out, but I will also be handing this off to Emery, who sort of led the network side of our analysis, and Cindy, who led the member advocacy side. But I'll give you a little intro and warm up. Next slide, please. We're going to remind you about what the RFI was trying to do, give you some first impressions, talk about who responded and who didn't. And then without naming vendors, we'll talk about some of the promising elements and stumbling blocks, both on the member advocacy side and on the network payment data quality side. And then at the end, we'll ponder what to do next. Next slide, please. The Lodestar was open from March through April. And you'll probably remember we sort of separated it into two hemispheres. One focused at members, the member advocacy side, and the other focused on running the technologies administration, sort of the provider side of the package. And so we focused on those key components. Remember we had 4 pillars of Lodestar: member advocacy, reference-based pricing using Medicare, incorporating payment for quality, and building in a global budget adjuster. We had 40 plus vendors who were solicited, and we had 17 responses. And I don't know about you, but whenever I throw a party, I have this sort of haunting fear that no one will come. But they came to our party, and we were really impressed with the quality and the quantity of responses. So that was very good news. Most of the NPDQ vendors suggested integrated solutions, but were flexible to work with others for member advocacy. Some vendors on the member advocacy side also gave us thoughtful opinions on the network and payment side. And then some specialty vendors who wouldn't do all of either hemisphere gave us great questions about both. So that was super nice. Next slide, please. These are first impressions. You're going to hear a lot more, but it's good, I think, to at least start with trying to boil it down. To different levels, the responses were completely custom to our questions. There wasn't a ton of boilerplate. There was some, but people listened, heard, understood, and replied. And I don't know if any vendors have called into our public meeting, but if so, thank you. It was wonderful to sort of have people seem like they were getting it. Overall assessment would be that the vendors are pretty close to meeting most of the key elements of the Lodestar model. You'll hear a lot more about this. On the paying technology was really quite solid. If we can put the specs together and the global budget and the quality adjusters and the fee schedules, et cetera, the vendors who are out there administering benefit plans can handle multiple plan designs, multiple employers, multiple fee schedules. And so the actual nuts and bolts of it looked like a relatively easy lift. On pharmacy, we did quite well also. We were kind of hoping for something that would be more out of the box on pharmacy, and we didn't quite know what we were looking for, and we didn't get anything that was substantially, breathtakingly new. The model of PBMs and formularies and trying to find the lowest cost drug through those formulary methods is relatively standard. We did get some reassurance on administrative simplicity, so the prescriber would know at the time of prescribing how that might interact with the benefits program. And we got a little bit of reassurance that the select care or GoodRx pricing could be available, but not necessarily integrated into the prescription drug program. And then I guess as a general theme, we sort of were leaning toward the prescription drugs being a relatively broad network with a big list of drugs and lots of providers. And we didn't really feel that that concept was anywhere yet in the responses we got. Mostly it is still maximize your formulary for savings. One nice thing we did see is that the rebates can be applied at the point of service in some cases. On member advocacy, we're part of a growing call for this type of solution. And so the competition is growing, and the ideas we're proposing are not out of the mainstream. Paying for quality, this is happening too. There are lots of programs. A lot of them are following the healthcare LAN model, as we have been. So I think we would have good partners to work with in refining a pay for quality approach. And some people have approaches they suggested. None of those were exactly what ours started as, and ours was not so specified that we wouldn't appreciate some collaboration on the paying quality related payment. The ability to do it, again, looks solid. We thought we had some nice specialty vendors. We had a couple that were focusing on getting those provider contracts with reference-based pricing and percent of Medicare, which was nice to read about. There were vendors who are very strong in the analytics and quality department and in member navigation. And on health equity, that's an evolving area. There's a lot of interest. We didn't feel like the specifics of great solutions were already crafted, but we thought it was great. On this presentation, we have a lot of slides and a fair amount of content. So I think what we're going to do is periodically stop. You can jump in at any time, although on Zoom it's always hard. But we'll periodically stop and see if there are questions before we move to the next section, and that's what I'll do now. Okay, then next slide and next presenter, please. Emery. Emery, are you on mute perhaps? Okay, let me ask some of my other team members. Can you see Emery on our list of participants?
Hey, James.
Hi.
I was going to say, this is Margaret. I see Emery. It looks like you're unmuted now. I'm not sure what the mic issue was, but I think we can hear you.
Actually, I was actually on my phone and for the best audio, so I was muted on that.
Okay, I'll shut up.
Okay, thank you. So on page 5, we have a list of those who responded and those who had interest but no response. So those who responded are at the top, and those are the 17. We will go through them in a little bit more detail. On a couple of the other slides. Those who have interest but no response were those who actually accepted the RFP but never actually submitted a response. I guess the big name on the interest but no response was Moda, and it was a little interesting to see that they didn't respond, but they declined to in the end, although did look at the RFI. Are any questions before we move on? Okay, so on page 6, we stratified those who responded into 3 categories. Some of the vendors who responded might feel that maybe they might fall in one of these classifications or not, but we wanted to kind of put broad categories to talk about how these respondents answered the questions and the type of solution that they're potentially proposing for the lodestar. So on page 6, we have those who essentially presented an integrated solution, something that's almost fully baked, well, in terms of all of the options and technologies and requests that we made in the Lodestar. If you take a look at these, a lot of these are more of the national, larger carriers. Some of those are like Aetna, Cigna, we'll put Providence in there, and United Healthcare. All Care Health did submit a response. They're a physician-led organization serving Medicaid and Medicare in Southern Oregon, and they did used to provide a health plan for Pebb from like about 2016 to about 2018, if I remember correctly. Signify Health is a technology company, but they also responded in collaboration with Regents and Journey. Journey is actually part of Cambia, which is the mother company of Regents. They do member technology and provide sort of a advocacy solution. So it's a essentially bundled together solution, while Signify handles a lot of the data aspects of it. The one that you might not have heard of, which is an interesting possible solution, is Bind. They provide healthcare where there's no deductible, but the member is essentially required to look up services and the cost of services prior to obtaining them. While preventive care is free, but then some of the other services, if you need to go have maybe, let's just say, a knee surgery or something, is the most extreme example, but even if you're going to the doctor to deal with maybe an infection or something like that, you look it up and there's a certain price associated with those doctors, and they use the pricing to guide you to higher quality or more efficient providers in that case. They do use United Healthcare for some of the pricing, but they handle more of the technology aspect of it. Any questions before we move on to the next slide? Okay. On slide 7, we have those who responded to both the network administration and advocacy, but their overall product or the questions that they're answered weren't quite the full meal deal. Not all the aspects were there. They were using additional like third-party vendors, or didn't quite necessarily provide a robust response in some of the sections. In this section, there might be some names that are a little bit not known for you. Going through the list, 6 Degrees of Health is actually a local-based company. So it's in Hillsborough, and they use data and technology to use set reference-based pricing and try to optimize healthcare spending there. Castlight is more of a consulting, I guess a commercial advocacy program, but they did provide more of a network administrator solution. So we moved them into this bucket versus the following page, which is more of just pure member advocacy. Comagine Health is based on what their website, they may not completely agree with this, but they're nonprofit healthcare consulting company, although they do a lot more, and they do manage the Oregon Data Collaborative. They are a merger of various companies. The one that you might have known about, but this was actually a couple mergers ago, was Q Corp. And I think they have presented to Pebb and OWEB about some of their quality and cost measurement. And then there's some other companies that also combine to create Comagine Health. ELAP is reference-based pricing with advocacy. Equitas DX is also another local company based in Portland, and they use data to really, manage costs and contracting. Quantum Health is another commercial advocacy solution that provided a little bit more of a bigger, more robust advocacy plus some network solutions here. And Healthcare Blue Book is mostly data analytics, although they did have some member advocacy questions. But they're very big into data, and they also purchase Quantros. You've probably seen some Quantros data. I think Willis Towers presented it for some of the COE information, but that's actually now owned by Healthcare Blue Book. Moving on to the next slide are those who essentially responded to only the member advocacy question. So Accolade, Grand Rounds, and Touch Care. And I'll turn it over to Cindy Ward to provide a little bit more detail about the advocacy solution.
Thank you so much, Emery. You can go to the next slide, Rose. So a little bit of background before we dive headlong into some of the member advocacy RFI responses. As a reminder for the group, you might recall that the purpose of the member advocacy component of the Lodestar was really to reimagine the member experience and to really ensure that members were able to get care at the right time with the right provider at the most optimum cost. So the model had several core innovations that we specifically asked about in the RFI. One is a single point of contact for members, an interdisciplinary team approach, the ability to seamlessly address behavioral health, substance use disorders, and social determinants of health. We wanted something that was really attractive and desirable for members so that we could improve engagement rates and rates of uptake to the member advocacy model. We wanted technology that optimized the member experience, but that didn't take away from a human interaction should that be the choice of a member. And then lastly, we really wanted vendors that could identify and address health disparities. So that was the context for building the components of the member advocacy part of the RFI. So some of the things that we heard in the RFI that were promising elements. One, the single point of contact and use of interdisciplinary teams seems to have become a market standard. Most of the vendors that responded to the member advocacy component had some mix of single point of contact and mix of interdisciplinary teams. We did ask specifically if there were some non-traditional staff that were in some of their models and that were showing promising results. And you'll see on this slide that we had vendors that are using non-traditional paraprofessional staff like community health workers, women's health specialists, lactation specialists, respiratory therapists, pharmacists, substance use disorder professionals. So that was really exciting to see from our perspective that these types of vendors are thinking about the types of supports that might be needed in order to address the variety of problems that members may bring to the table. One of the things that was not as prominent and slightly disappointing as we were really looking for best in class, what these vendors are bringing to market, is a lot of these models, even though they have pretty robust and diverse interdisciplinary teams, they tend to be mostly telephonic based models from what we were seeing. We didn't get a lot of responses that really showed folks getting out into the field, really integrating into the community and having the opportunity to do those one-on-ones, especially with members that might be difficult to engage. So that might be an opportunity area for us moving forward. You may also recall that part of the member advocacy model integrated UM. We wanted one-stop shopping for the member. So if they needed an authorization for a service, we envisioned that the member advocacy vendor would provide one-stop shopping for that member to get the services that they need authorized, identify the provider that's best to support them, and support the member in any way that they needed from that point forward. But we did see one interesting model that honestly I had not thought of from this perspective. But they deliberately did not do utilization management functions. And what this allowed was them to really position themselves as the advocate for the member. So they would interface with the vendor on behalf of the member. And if services were denied or services were having difficulty getting authorized, or there was an appeal or a grievance that needed to be filed, they really positioned themselves as the advocate for the member. And that seemed really interesting given some of the core components we were thinking about in the Lodestar model. So it's definitely an area as you start to look a little bit deeper, maybe under the hood yourselves, and thinking about where we might adjust the Lodestar model. I'd love to get folks' thoughts and insights into whether this is a strong positive or if this is something that really might not work for the model. Just found it something definitely worth considering. James talked a little bit about health disparities. I think most of the respondents demonstrated some sort of response that talked about at least a general understanding of health disparities, how important they are, and responses that sort of alluded to a plan and a process to get to health disparity identification and addressing them. But they were not very robust responses overall. There was definitely a lot of opportunity for improvement. This is just a growing interest area nationally. There's a lot of focus in this area, especially from national organizations like CHCS. So there's a lot that's happening in the innovation space here, and it didn't seem to translate very well to some of the vendor responses, which was a little bit surprising. Two of the vendors at least indicated an ability and a desire to align with Real D. So we were excited about that. Some of the other vendors really didn't speak to it, even though we specifically asked for it in the RFI. And then finally, we did see some other promising practices, some incentive payments models for providers and incentive payment and incentive models for community resource organizations. So going beyond just incentivizing providers to improve healthcare outcomes, to moving that to community-based and resource agencies within the community who also may be contributing to improving the health outcomes and health disparities in the population. And finding the right provider. So this is kind of core to our philosophy in Lodestar of the right service at the right time with the right provider at the right cost. And we saw varying degrees of responses here. So I think overall, I got the sense in reading the responses that there is competency here, that most of the vendors are building something or have something in-house that helps them identify what they would consider to be a quality provider. Where the detail lacked was, how do they define quality? How were they defining value? How were they evaluating those providers? And what was sort of under the hood in the analysis component of how they identified them? And I think that I got the sense in reading some of the responses that most of the lack of detail probably stemmed from the fact that they consider this to be highly proprietary. So it's probably an area where if we were to move forward with an RFP, we would just have to add a level of specificity to get the detail and differentiation between vendors should we be evaluating them for an actual RFP. And I'm going to pause now for questions from the group.
This is Tom.
Hi, Tom.
My question has to do with the connection that the vendors, particularly around the member advocacy, have with existing delivery systems, because and it shows my prejudice in that I am a retired physician. So my focus always has been the delivery system. And all of these things that are listed out here, what's critical is how the service is being provided by the delivery system. And what I haven't heard is the connection of these entities with the existing delivery systems in Oregon?
Tom, I think that is an excellent question and a very fair point. The way that we structured the RFI may not have given us the best ability to dig under the hood. We separated out some of the network questions from the member advocacy questions, and we asked about linkages. We asked about how they outreach providers, but I don't know that we got enough detail just thinking through the questions that we asked and the way that they were responded to fully answer your important question. Emery, I don't know if you saw anything that helped you get a sense of their abilities and how these vendors approached engagement with the delivery system more strongly.
I don't think I unfortunately can't answer that right now. We'll actually take that away and dig more into that for next month's meeting.
Yeah, and the additional again, I'm putting on not my physician hat but my OEB hat. We have presence with school districts that are in very, very small communities. So a solution that works in Portland or the metro area or some of our larger population areas will also need to work in Burns and much smaller communities scattered across the state. So that's going to be the additional challenge to the discussion that we're having and the innovative activities that Lodestar has woven into it.
I appreciate that feedback, Tom. I think it's really important, and I'm making a note for us to do a little bit deeper evaluation of that as well. Any other questions before we move to the next slide? Okay, Rose, I think we can move forward. So I wanted to share some of the areas where we felt like there were opportunities or there may be things that we need to think through in the Lodestar model that may be, hey, now looking at the stumbling blocks is the title, that may not be the right wording. It may really truly be opportunities, but for some of these, where we really were pushing the envelope in innovation in the Lodestar model, we're in some of these areas that I'm going to speak to. And one was member engagement. Traditionally, in models like these, there's if you get 20% of the members that you identify for outreach to actually engage within your program, that's considered good within the industry. We were really looking for models and vendors that really were thinking through what does it take to make a member advocacy model that is truly attractive to members and that pushes the envelope. And we set a standard at 70% engagement rates. So if a member was identified as potentially needing this service, that the outreach and engagement rate would be around 70%, which is really ambitious. We didn't get a lot of innovation noted in meaningful ways of making the service more attractive to members. Now, a lot of the vendors talked about how great their model is and that members like it, but we specifically asked for numbers and how they were engaging and showing us some outcomes, and we really didn't get that level of information. So it's not really clear if any of these models are doing better than what we would see in the general market from a member engagement perspective. We also asked about real-time out-of-pocket costs for members, and we had some vendors that talked about the ability to do this, but they were really talking about a member's out-of-pocket for the year. So if there's an annual out-of-pocket cost, they would speak to the fact that the member could call in and talk to a member advocate or someone else and get what their deductible would be for the year. What we were really talking about as the innovation in Lodestar is that tracking over time, so that at any given point within the year, a member could call in and say, and get the information of exactly how much of their deductible they had left, How much exactly would be out of pocket should they go and have this service at this provider? That was kind of what we were looking for. So we didn't get a lot of strong responses in that area. So it's hard to say if there's a high level of competency here. We talked about the integration of utilization management. It's a component in the Lodestar model that we asked about. And this was a mix. So a lot of the member advocacy models out there, they've either chosen not to have as a core function that they provide, or they might have it, but it's not an integrated function. And what I mean by that is, in large carriers today, utilization management and care management or their member support programs tend to be separate, and they may even be on different platforms, so they don't necessarily speak together. We didn't see a lot of that cross-functionality that we were hoping to see from an innovations perspective. Although there were some promising practices, we felt like this was an area where we still had opportunity to get deeper innovation out of the market. And then I guess probably one of the most disappointing from my perspective, just because this is a passion area for me, I don't, people don't come in medical issues and behavioral health issues. People come with both issues and probably an array of others together. The level of behavioral health integration really was limited to speaking about having a behavioral health person on the interdisciplinary team. We didn't get a lot of responses that really demonstrated that vendors have core competencies in this area, that they really understand how behavioral health influences poor outcomes on the medical health side. There just wasn't a level of expertise that I was hoping to see in the responses that we had. So again, this to me is a big opportunity area when and if we would move forward with an RFP, to make sure that we're really vetting vendors that understand that this is a critical component to both the model and to caring for members who have the most needs within our population. And I'll pause for questions.
Again, this is Tom. The issue of behavioral health integration is something that occurs at the delivery system basis. So I'm not surprised that the vendor is not going to be, I think they would advocate for it and say this is a requirement, but it's the delivery system that needs to figure out how to make those things, how that change. Integration and these type of important changes are important at where care is being delivered. So I'm still struggling with how a vendor, taking this last example of behavioral health integration into the provision of care at kind of at all levels and complexities of care that's occurring. I don't know how a vendor is going to address that. It would seem that the importance is that the delivery systems are addressing it, and that the financiers of the delivery system acknowledge it and pay for it. I don't know. I may be missing something, but I keep
I don't
coming
know that
back
you're
to
missing.
that.
So Tom, you're absolutely correct. The member advocacy vendor can never take the place of what's happening in the delivery system. What we've envisioned for Lodestar is, if a member calls, they are calling to get access to a service. They are calling because they have a problem. They are then screened. So that it's not just that I address okay, I need to find a provider. I feel like I have carpal tunnel syndrome. I need to be seen by somebody. What we envisioned in Lodestar was that vendor would really holistically be assessing that member and understanding other factors that might be influencing their need to access care, or their need to access different care, depending on what they come with. So in in more innovative models, what happens is you're screening also for behavioral health. If I am reporting anxiety, if I'm reporting that I, can't, if I have a social determinant of health issue, a lot of that could stem potentially from behavioral health issues. So the idea here would be that they have a level of behavioral health competence enough to be able to identify behavioral health issues, to screen for those, and direct the members to the appropriate care within the delivery system, and have those relationships.
So the idea is to build an additional relationship outside of, for the example, the patient-centered primary care home, because I would view the responsibility of when an OEB member or dependent has a medical issue. My expectation is that they would be within a primary care home, and that primary care home would have the competence of being able to make that assessment of what are the elements that are going on, and take into account things like social determinants of care and other aspects. I'm confused by the value added of having putting in an additional step. Now, if the person doesn't have linkage to a primary care setting, then that's a different issue, and I understand that. But I can't imagine the vast majority of people going first to a vendor as compared to where they get care. And
right. Ideally, you're right, Tom. The access point would be with a trusted provider if you have that relationship. This is definitely something that should be supportive of that relationship, that directs members back to that relationship whenever possible, but is also there to support members who may not have established those relationships or need assistance in they've called just to understand their benefits. They don't know where to go, that they might get some guidance.
No, I understand that part. The person who does not have a connection, we definitely need some type of robust navigation effort to be able to, that looks at the patient more than just, as your example, wrist problem, numb hand, whatever.
Exactly.
Okay, I'll shut up for a bit.
No, thank you so much for the feedback. I deeply appreciate it. And Rose, I think we can move to slide 11, and I will turn things back to Emery. Thank you.
Thanks, Cindy. Next few slides kind of breaks up the NPDQ, the administrative functions, into various sections. On the first slide, we are talking about general administration. Overall, we don't see significant roadblocks for just administering Lodestar type plan or network. In terms of paying providers, most can administer and pay providers on a percent of fee schedule. Once that fee schedule and amounts that are determined, the vendors can implement those fee schedules and pay them. They can administer multiple fee schedules, and coordinating multiple plan designs, such as those, especially on the OEB side, is not an issue. And generally, coordinating with an advocacy vendor will not be an issue. So just overall administering of the plans, no real significant issues there. Some places where we did receive some feedback where they might have shown some concerns, the amount of complexity or changing fee schedules too frequently might be an issue, especially if we're calculating or quality metrics and potentially taking a look at the quality of the providers beyond annual basis. So on an annual basis, there's not really any issues, but beyond that, you might run into some issues. Data feeds. A lot of vendors said they can do multiple data feeds, including up to daily. However, some do say they only provide those on a monthly basis, or would do it on a more frequent basis, but would charge for them. So there's a little bit of concern about too frequent feeds and whether that's something that's standard or would have to be paid for extra. And in terms of social determinants of health and health equity, I try to identify culturally competent providers, or providers of different race, ethnicities, or LGBTQ. Not all providers have that ability. Not all of them are currently doing it, and finding that information is difficult. So it's not quite there yet in terms of necessarily putting together a provider network guide where members can look it up and accessing that information. Okay, moving on to the next slide. This is the first of two slides on provider payments. There was kind of low enthusiasm for really significantly reforming how providers were payment. There wasn't, while no one was overly negative, there wasn't like too many instances of pushing the envelope the way we like to think the lodestar is, increasing the amount of VPP payments, or tying in how providers are being paid, or reforming it the way that we were talking about. On the positive side, there are definitely a lot of vendors who do have networks with reimbursement levels, essentially on a percentage of Medicare basis, that are below the 200%. So 200% may not be, I guess, the threshold. Some are going below that. Some vendors have integrated variable payments based on quality metrics, performance and quality metrics into their network. So it's not just performance. I guess it's an advanced form of performance guarantees in this case. And episodes of care payments are in place with some vendors. So they're paying beyond just fee for service is there, and it's possible. As mentioned earlier, there wasn't significant enthusiasm, and very few have shown that they were providing or reforming payment. Most proposed their current networks, which don't have a significant amount of payment reform. There are value-based payments, and there are, but it's not necessarily to the degree, put 30 for the lodestar, we're saying about 30%. None of them really talked about going to that level of value-based payments in their networks. Too much complexity was a potential issue as well. So keeping it simpler is currently what's in place, and would potentially get more buy-in from providers if it's simpler. And a few vendors did talk about the willingness of some providers to assist with addressing social determinants of health. This was something that we specifically talked about, trying to improve social determinants of health and addressing those. And there was a little bit of pushback from a couple of vendors about whether they felt it was going to be possible. In terms of contracting for across the state, and especially in the rural areas, there was a little bit of concern about performance guarantees and value-based payments for some of the smaller providers, especially in the rural areas. So that's an issue. We had a question as to whether any of the respondents had concerns about trying to reform payments. None of them really talked about contracting, significantly contracting, having major issues, or being able to contract in rural areas. So, I think that is a concern, whether, how much payment reform is possible. I think potentially doing more stakeholder meetings and things could be a next step, but there weren't direct answers as to, oh yeah, definitely we can contract like this across the state. So that is an area of concern for provider payments. In particular, of note on slide 13, on the next slide, there were two respondents that had mixed responses about payment reform. So on the positive side, there was one who had talked about providing financial incentives, additional payments, increased payments for hospitals with improved quality and efficiency if they met agreed upon improvements. This was in place with over 100 ACOs, and it's similar to what's currently being proposed for Lodestar, and they are increasing the amount of percentage and the financial reimbursements tied to those incentives. So there were steps taken to reform payments, sort of in the vein of where we want to go with Lodestar. But there was also one respondent that had some concerns about payments. They've noted that changing payment methodology where you increase capitation payments to providers and decrease the fee for service portion of it did not actually demonstrate improved care. That they saw improvements, but it's really through additional funding, so higher funding and the quality improvement technical support, so the support provided to those providers to improve care. And they also mentioned that maybe going across a larger total cost of care risk arrangement, encompassing more of the, a larger swath of the delivery system, would potentially create a culture of quality improvement that would permeate throughout the entire care spectrum in that case. And that might be a better way of approaching payment reform.
Emery,
Yes.
just to talk, this is Tom again, to talk about that point you just made of increasing costs that looked at improved quality of care. When you said but that it actually increased costs, was that total cost it increased, or was it just, let's say that's built into a primary care system. The thought is that you enhance primary care capacity by both paying for fee for service, but also then a capitation to be able to manage, to do case management and outreach and some of the other things. The thought is it increases the cost at the level of primary care, but then when you look at downstream costs with imaging, hospitalizations, emergency room uses, et cetera, the total cost of care is diminished. So are you saying that the model of enhancing primary care with case management and other advances doesn't result in total cost of care being decreased? Because that's different than what I've heard.
Yeah, I would have, in terms of the response, I think to your point about increasing, increasing care management, helping with that, increasing payments for primary care in total. From what I understand, that has improved care. I think it was more of the response was more in line with, well, if you have a certain amount of money and how you pay it, did not, like the split between essentially a capitated payment and fee for service, and just changing that mix from, let's just say 90-10 to 80-20. That really didn't have an impact.
And that doesn't, but that's not the model that people, having it the same amount of dollars going to an entity, but require them to do more. So you pay for the case management and outreach and systems analysis, that data analysis capacity, and you pay for that, but then you decrease the other costs, and it turns out to be a total. That's a fool's game.
Yeah.
Okay.
Yeah. Yes. And-
Again, I'm sorry for
Yeah.
throwing these details at you, but
No, definitely. I mean, with Oregon and the the primary care being what it's supposed to be about 12%, at least 12% paid for primary care.
right.
To improve. I mean, those are definitely goals, and I think one of the goals of the Lodestar, as it was originally designed, was to essentially change how not just the payment mechanism, but kind of almost rebalance who gets paid what, to increase payments for primary care, primary care homes, behavioral health, those substance abuse, trying to address those providers who might not be paid as much, who might need more additional support to increase the primary care payment as well to meet that. And and to potentially reduce the costs on some of the more, I guess, the commodities, right? Or I guess in this case, the hospital systems, the facilities getting paid above 200%. Some of those savings would then be transferred over to primary care to increase those, payments there to help them with the care management. So that was definitely some of the intent of Lodestar. It was part of the presentation that they saw, and I think we're on the same page. And it wasn't necessarily, I didn't really see responses from the RFI that completely addressed those, but it's definitely at least in the Lodestar, and it's part of our intention, which I hope is in line with.
Thank you.
Yeah. Before we move on from payment reform, provider payments, are there any other questions? Okay. So page 14, next slide, talks about data and quality metrics. So this is the first of two slides on that. So there are definitely advanced data analytics and quality metrics that are available. So it's not just NCQA, and HEDIS metrics, but what else is out there, and what databases are available to help the advocacy vendor, and also, also I guess the plan administrators to try to improve the quality of care, or to measure providers, to steer members to higher quality providers. And on the positive side, there were a few vendors that had quality and efficiency metrics beyond just the NCQA or HEDIS metrics that can be used to help stratify providers, and that they are actually doing so in some cases. So that was definitely encouraging to see. The data reporting would provide access to the advocacy vendor, or even Pebb and OWEB staff. And in terms of social determinants of health, a lot of the vendors are trying to mine or integrate outside sources, CDC, census information, to at least identify or to address potential health equity issues or social determinants of health. Some less than positive feedback. In terms of the quality and efficiency metrics, there were a few that were noted, and some of the respondents actually utilized other respondents for their data analytics. So that was a little interesting to see that there were maybe a few respondents who were some of the best in quality, or because some of the other vendors noted that they were using them for their data analytics. There were tiers, levels of ability to the respondents to provide these levels of quality metrics. So some definitely shone, and some were did not shine quite as brightly. And in terms of the databases, some would incorporate it, and some actually weren't quite able to incorporate social determinants of health data. So the ability was a little bit limited there. On the following slide, Some positive feedback, additional positive feedback was there are vendors who had software who could identify gaps in care, and safety issues, and identify unnecessary services. So trying to address some of the waste, and not necessarily fraud, waste, and abuse, but potential waste in the system, or issues that could be potentially addressed. Some of the vendors have worked with the Oregon Data Collaborative, and in terms of electronic health records, most have the ability to integrate the most popular health records. I don't think anyone said they could do every single health record that's out there, but most of them could be incorporated into the data analytics, or they could use it, gather data from those health records. Some on the less than positive side, in terms of the quality metrics, there was quite a broad range of quality metrics that were proposed. I mean, I think there were different levels of what people could provide for quality metrics, and I think that kind of tied into what they proposed as well for measuring performance for providers. So there were tiers to that, and pretty wide range of varieties. In terms of potential scorecards to measure performance, there was a lot of the providers. Some of the providers talked about, well, let's talk about this further. They don't have necessarily which is, a good thing. I mean, you want to be able to make a scorecard that's definitely, tied into what Oregon wants, what Oregon needs. But it was a lot of, okay, we need to talk about this, and let's discuss, and maybe a next level discussion or follow-up point for the Lodestar. And the final one, which isn't necessarily with the RFI, but it's an issue that would need to be addressed. There are rules about prohibiting payments for metrics that aren't currently approved by the metrics committee. So, there would need to be some advanced work if we were to potentially use some of these advanced quality and efficiency metrics, which are, in some ways I guess in a lot of ways proprietary to the systems, and not necessarily something that could be, I guess, it's not public, and incorporating those to, pay providers differently. So there would need to be, work done to make sure that the Lodestar vision, or in terms of steering higher payments to higher quality providers, could be actually implemented in this case. Are there any questions on data and quality metrics? Okay. Moving on to page 16. One slide on pharmacy. There are some good things about prescription drug pricing, but there wasn't anything that was what we felt like was truly revolutionary. So on the positive feedback, as James mentioned earlier, there was the ability for some vendors to provide what we would call true cost pricing, where rebates offset the prescription drug price for the member cost share. So, for a drug and there's a rebate, that might, if the member's on a percentage coinsurance, they would pay a lower cost, and some of the rebates would then essentially accrue to the member rather than just the plan. So some vendors can do that. Some of the respondents have tools for members to find pricing information on their drugs by pharmacy and specific drugs. And in terms of positive feedback, in terms of trying to lower cost, one vendor respondent said integrating medical and prescription drug administration, to tie that all together with that single administrator does result in lower costs. So that's so having a third-party PBM actually ended up having some additional costs compared to having that all totally integrated. So that was something to note. And then on the less than positive feedback, while some vendors will assist with non-insurance RX card discount pricing. They're not actually integrated with the overall out-of-pocket cost. So those claims would essentially be paid out of pocket and would not be part of your out-of-pocket limit. It wouldn't actually be part of the medical RX plan in this case. Or, in some cases where manufacturers provide cards or coupons for high-cost specialty drugs, they talked about, there's a potential to save money for the plan if you increase the out-of-pocket amounts that the members would pay, but then that gets offset by these rebate coupons, drug coupons. And so, it's more of a cost shift than to save money rather than, I guess, more holistically looking at trying to improve members' care. And also savings, a lot of the vendors talked about savings, but through formulary changes and, tightening efficiency there, which is another, potential disruption to changes in prescriptions per year, or, looking at site of services as well, which can be a good thing and save some money, but also does provide a little bit of disruption to the member where they have to potentially change where they're getting services or take greater responsibility on knowing these programs exist or knowing where to get their prescriptions or injections in this case. Any questions on pharmacy?
Yeah, this is Tom again. Do any of the vendors work with their with the delivery system around what drug is prescribed? In the OEB experience is that we have seen MODA has had some, I think, really important changes by addressing site of care, and Kaiser Permanente, the other medical plan, has been able to have, I think, profound control over rising pharmacy costs because of the way that that delivery system looks and approaches the use of drugs. So I know that the people outside of the delivery system are talking about rebates and formularies and all of that stuff. That seems to be dancing around the fundamental question of appropriate drug, step care, things like that. And so do the vendors do any of that?
They do talk about it. I think that one vendor that talked about the integrated, it's not quite to the level that Kaiser is doing with being both, the medical system and their own PBM. But I think part of the Lodestar, the responses, I'd have to check. I don't recall any responses that directly was on point to your concern or your point. I'll double check on that, but no, but I definitely agree with you and note that I think overall management of drugs is that's an interesting thing. I don't want to step out of my lane. But we'll note that and see if there's additional gleanings in the follow-up on pharmacy and overall integration. I just don't recall any at this point.
Emery, there were a few examples where the vendors talked about the prescriber being pretty well informed while prescribing about, the cost of the drug and the cost the member would see. But I think we can look through those proposals more.
Yeah, I think Jeff's trying to jump in. Go ahead, Jeff.
Yeah, I was wondering, where you have a plan with low co-payments, how the true cost pricing benefits.
Jeff,
Yeah.
some of the respondents had the same question. If you have very low co-payments, why is that so important? And they did say, you know, in the high deductible world, some of those things are more important.
Yeah.
At sort of a incentive level, there are a lot of people who think that rebates and rebate games and shell games around drugs are not necessarily good for the entire system. And so part of the true cost was just on transparency as well as on accuracy.
Yeah, well, I'm all for transparency because it does feel like which walnut shell is the pea under at times.
Yeah, I mean, I just to follow on what Tom and actually what Jeff just said, that for me the cost and the pricing and the transparency related to pharmacy has more to do with the health system and the provider than the individual. Like, setting aside for a moment the scourge of direct pharmacy advertising to consumers. Theoretically, the person that should be making the choice about the medication is the doctor, the provider, unless someone's trying to be their own doctor, which they shouldn't do, even if you're a doctor. So, so for me, I'm always wary of plan design things that is trying to control behavior by putting it on the person, although there's some place for that. But in particular around prescribing behavior, that's a that's a that's something that the transparency and the responsibility should be at the provider, the medical system and the provider. And so that's kind of what I was going forward, what I would be thinking about related to transforming prescription drug pricing and administration is more at that administrative prescription level, kind of like what Tom was saying, like Kaiser does, where it has like there's a best practice kind of regime of prescribing on certain drugs based on efficacy, safety, and cost, and that's how they do it. And you can get exceptions to it, but you have to have a good reason. So anyway, that just kind of going forward, I wouldn't want the whole emphasis here to land on trying to inform an overburdened consumer or patient. It's for them to navigate all of this business. This is kind of the provider level to me.
Thanks for that feedback. We will definitely note it. It has been, at least in terms of the responses, yeah, it definitely looks like it's a lot of putting the onus on the member, which isn't really the intention of the lodestar in this case. On the following slide, we're in terms of health equity, there are steps being taken to address health equity. There was a little bit of concrete improvements, in terms of savings and addressing health equity, but there was, it's still not necessarily in the nascent stage, but still being developed to really address health equity. In terms of positive feedback, some vendors do stratify or use cohort matching to try to identify members who may have health disparities. So kind of matching similar like members and then mining that information to see where health disparities or outcomes were different between those members with chronic conditions or facility readmissions, taking a look at that. So taking actual
concrete steps, mining the data to try to identify these potential health equity or social determinant issues with the members' health. One respondent has invested in with community health workers to try to help their members navigate health and social service systems. So that was nice to note. And few respondents have created internal groups to try to address it. So, they are thinking about it, they are trying to address it internally or have pledged money to try to address these issues. So their steps are definitely being taken. But, their data access to good and reliable data is not quite there. There's a lot of assumptions being made where you're trying to potentially identify members who might have social determinants of health or health equity issues by using basically matching based on zip code. So, based on the percentages of members who might be living under poverty or food desert areas based on the zip code, using that to potentially stratify members. It may be applicable, it may not be applicable. So assumptions are being made, and hopefully you can address it in total and it affects everybody. But it's not necessarily the members that you're trying to address in that case. Mentioned earlier, limited examples of demonstrated improved care or savings achieved by addressing health equity. There was one talking about reducing or finding out areas where there were readmissions differences due to the social determinants of health, and then actually creating an action plan to solve that. So there was one step there. And in terms of trying to identify, there is a lot of data work that needs to be done to identify it. So there has to be a concerted focus on social determinants of health. And this could be potentially hold back right now. And as it's still being developed, there could be great improvements, but it's a lot of work right now, and for trying to identify potential areas where you could improve health equity.
So, sorry, Emery, were you done with this?
Yes, I am. Go ahead.
Okay. So there's quite a few topics mixed together in this one topic, and going forward, perhaps we need to clarify or separate them more in order to get more nuance what we're looking for. So first of all, I just want to say investing in community health workers is that's a great response. Like that's the real deal, and kind of to some degree what I was looking for was that kind of thing. So I don't want to dismiss the positives that we got. The other thing, there's a lot of talk about data, missing data. We can't tell. There's a lot of that. It's true, but I think that there's a sort of package of problems that the system that we're all trying to address. One, there's just well-known there's different health outcomes, and those are measurable and have been measured. So I don't feel like we need to reinvent the wheel there. But as far as why, part of it is distrust or having been mistreated, essentially, based upon your needs by the medical system, whether it be language access or, microaggressions, that kind of thing. That's another thing. And then there's another item which gets to more of the social determinants of health, which is like where you live. And those are some pretty different buckets. And I would expect that in Oregon, most of the medical systems at this point should be, if they're not already, working on identifying those instances of mistreatment and microaggressions as priority one, because that's something that they actually can influence. And that's probably, I mean, that's it feels hard, but it doesn't have to be um, that complicated. I mean, on some level, this is a survey. Like, how were you treated? Like, how do you feel? Why didn't you go get your annual exam or whatever of your members? And trying to feel, get responses that are like, I don't feel comfortable. And then trying to, concierge style, try to reach out to those people and figure out why that is and what can you adjust inside your system. So I don't know how going forward, how we would word that in trying to provoke that kind of response in a RFP, but that's part of what I would be thinking about is um, uh, access to language translation services, like easily making people feel comfortable, like they can see some of the doctors, nurses that literally reflect them, their background, and also, you know, really getting feedback about how the system is doing in helping these people feel welcome. And sort of a lot of large organizations are kind of anthropologically looking at their organization, like how is this set up? Uh, Literally things as small as like intake, you know, walking in the front door. How does this reflect sort of white supremacy kind of um, assumptions, and thus turn off various people? And so some organizations just diving into that feels like the way to go, and not necessarily that expensive or out of range. It's just more of, approaching it. So maybe we have to think about how we word that going forward, because I can see how if someone trying to address all of those buckets all at the same time, as if they're one idea, could be overwhelming. But there's some things that can be kind of broken down here. So I'll just say that for the future discussion, feels like there's a little nuance we can introduce there to make this a little more digestible for folks. But it definitely feels like we hit the mark a bit, because we did get some response. Community health workers feels like completely appropriate response to some degree, but also thinking about the provider network and their welcoming atmosphere to different types of people, literally the way they've designed it. So we can talk about that more later. I'm just kind of putting a pin in that for later.
Yeah, definitely, Sean. I mean, there's definitely a lot around this. I just want to say, my focus, at least on this slide, was more around the data aspects of it. I think a lot of what you're talking about, would be what we're hopefully trying to achieve through the advocacy, and guiding them, and in terms of some of Cindy's responses as to addressing social determinants and stuff like that. But with an RFI, yes, there's a lot of nuance that I think wasn't in this RFI that definitely can be teased out in next level steps, and really addressing and refining in the lodestar. I mean, with especially on the Pebb side, what you guys are doing, but in incorporating those elements. But there's definitely a lot more that can be done, and hopefully we can achieve that pretty soon. Jeff, did you have a question?
Oh, I was thinking internally. I mean, so I'm kind of, I think I'm synchronous, or whatever the right adjective is, with Sean. I think when we get to our paths forward, I see a whole mixture here. Um, I like aspects of the local advocacy, people familiar with our environment, um, and our delivery systems, so on. So I just want to keep that till we get to the paths forward.
Actually, we can actually move to the paths forward because the next slide's kind of a summary slide of a lot of the things that we just went over. So if we can move to slide 19, we can talk about paths forward, and I'll hand it over to James.
Yes, paths forward is the big question. I should just say this was intended to be somewhat of a summary because the RFIs have only been in for a week or two. Now we got deeper and went farther than I originally expected, so it's a pretty thorough summary. And we have one more meeting before a couple months off, Jeff. So this first slide, or this number 19, sort of goes through what probably is obvious. We could take some of these really good ideas and think about adding point solutions or supplementing our current offerings. We could take a little bit of a multiple item menu approach and pick a few things that sounded really interesting and see if we can inject them into our current practice. We could do less than the full meal deal on a Lodestar Lite, where we could try to have the member advocates and data analytics and strong plan administration, but maybe back off a little bit on recontracting a whole new network, and instead use the metrics to highlight quality and efficiency. And then the gold standard that we threw out to see what people would say was kind of a new offering where we do all that, plus we have provider and provider group and health system contracts, which are customized to kind of do what we want done in terms of quality related payment and what we want done in terms of meeting our cost budget. So that slide may be pretty obvious. I'll wait to ask for questions until we go through the next one because we are running slow on time, or short on time. Slide 20 is just, a couple little ideas. These are not meant to be exclusive. We're there. So we want your questions and your feedback, and if you want to get more involved, that'd be great. We thought that we would revisit the responses and think about some of the best in class, or like how close we can get. We thought that we should, after getting some constructive suggestions, think about whether the Lodestar conceptual framework needs revision or just enhancement in certain areas. Maybe prescription drugs would be one of those. And then try and think about the path forward. And then some of the things on the right-hand column, we have not yet engaged or been engaged by the provider community. And I think at some point that's a very important thing. And our RFI vendors pointed out that this doesn't work unless the providers are willing to work with us. There's still the idea of whether this idea is so big that it would be better served to have more broad payer representation. So I almost sometimes wonder about the Medicaid populations that are left in a fee-for-service that are not already out in the CCOs, and whether some of the structures for the Lodestar would be helpful there, or just other employers who are looking for a strong option for a broad member advocate approach. The price, financial implications of doing this, something we have talked some about, but a project plan and a project budget to try and go forward would be something that you could ask us to do. I don't know if you can ask us to do all these things. And then at some point we need to decide how we're going to decide. So we could maybe take the minute we've got left and see if there's some direction from you guys on what you'd like us to focus on between now and June, and any early thoughts on whether there'd be some summer scope of work.
Wow. Well, thank you. You gave us a lot to chew on. I'm wondering, and I may be totally off here, if there is a way to look at it where we can parse it in different levels. In other words, what can be done locally? What do we really need to go outside to do? What can be developed? What do we need to buy right now? You know, that kind of a matrix from a recommendation standpoint. I don't know if that makes sense or not. Maybe somebody else can say it a different way.
Jeff, this is Tom. The only other, this last point raised about, what's happening with the providers and delivery systems. There is this value-based pricing work that's happening, which I think dovetails into this significantly. So I think we need to see, and I think it's exactly true that this only works if there are significant changes across the board in the state in regards to how the delivery system works and how it funds. So how things are funded. So I think we're going to need to see how this value-based payment, I mean, OEB signed on to it. All the, most of the major health plans have signed on to it. It's, and it has, I think it has some energy. So we will see over the next little while. And it's very possible that that will really play a significant role in one of the major components of Lodestar, which is the, how you get that, the coordination of care and moving away from fee for service. So I'm interested in seeing how that plays out. Yeah. So it may be that we, that we, moving forward to an RFP, I think without waiting to see where the value-based pricing effort in the state goes would be premature. That's just my thought.
Tom, are you referring to some of the, like the compact where the...
Yes.
Yeah.
Yes, the compact.
Yeah,
and there's a work group.
Yeah.
There's a work group that's getting put together on it.
Yeah. And that's relatively powerful and relatively new news.
Yes.
But if everyone's going to be under 3.4% anyway, yeah. We could breathe a sigh of relief and not do all the heavy lifting ourselves.
Yeah, exactly. And if indeed this thing does take off, and it maintains the kind of the involvement and commitment with the major players in the state, then it really does. That is the heavy lift.
Yeah, our early development work, we thought we would be somewhat of an early adopter or a case study potential option for the Senate Bill 889 kind of goals, but it is interesting to see what's happening.
So,
sorry, I didn't mean to jump in, James. I was just going to mention Tom's correct, and we Pebb and OEB do have seats on that compact, that committee on that value-based payment. So how fast they move, I'm not sure. They're just getting started, but we'll see.
Yeah. Tom really articulated what I wanted to say. I totally agree. So What's interesting me, the most interesting thing about all of this, I mean, there's lots of kind of interesting nuggets, but the kind of core of it is getting away from fee for service, right? So that's, and one of the slides that you presented, not surprising to me, was like, you know, the responses were not particularly interested in that that element, right? And so just like Tom's saying, and the question you asked, James, like wondering if we're big enough to do that alone, and I think the answer is no. All the more reason why we should be rowing in the same direction as some of these other statewide efforts, because I think what we're seeing here in this response, which is congruent with other things we've observed, is generally speaking, when you ask for this to be done, the answer is too hard, don't want to do it, not interested, or at the very least, just kind of lukewarm response. But it's a plate tectonic shift of healthcare, and no wonder no one wants to be the the one to bite it off. But that's what's super important to me in this. And so I'm wondering, James, if part of the task at hand is for someone or some people in our collective here to compare notes with Jeremy Vandehey or whoever related to that effort. And this is what we found. How does this help or fit or timing, that kind of thing?
Yeah.
Just to compare notes over the summer. There's also, in addition to the uh, to that effort, there's also some talk of some kind of regional pilot for such a thing. Somehow that might fit as well, but it's all like timing. Like, what is this? A couple of years off? Is it this year? Is it like in a decade? So somehow we need to fit with that stuff, though. And I do feel it's important, though, that we continue to, on some level, move forward,
Yeah.
because it's like one more signal in the field that lots of things are heading that way, including us. And so, people need to start designing it and getting serious about it, because it's not going to go away. So anyway,
Well, if we get behind it, we're adding urgency to the whole thing.
yeah.
Yeah, and to the extent you are big programs, but maybe not big enough to change the entire world, working together and being willing to take a different kind of early adopter role could be an interesting outcome.
So let me ask an opinion here to kind of close this off. I know we're over the time allotment briefly, but the provider community in Oregon is the sense that they are more interested in working within the state boundaries than they are working with entities outside of it. That's been my belief, but I could be wrong.
I didn't get any, I mean, it makes sense, Jeff, but we had both strong local and national responses.
Okay. Okay, so do you have direction for the next meeting? We left you hanging.
Well, maybe we'll formalize some ideas and some questions and then hit those hard in June. And we can take a little time we don't have to get it perfect now. We can ruminate for a night or two and see what we think we should package together.
And then lay that out at the planning meeting.
Yeah.
Well, thank you. There's a lot of good work in here, so I appreciate it.
Yeah, it was fun. Thank you.
Let's take our 10-minute break now. Let's make it 8 minutes and get back at 3:15. and it's 3:15.
Great.
Got everybody back on?
Yep. Yeah, it looks like I think everybody is tuned back in. We'll go ahead and get started with the next agenda item. The other main topic that we wanted to cover in today's meeting is an update on the status of performance guarantees for Pebb and OEB contracts for next medical plan year. This is truly a joint effort. Just to give a little overview on the focus for today, we'll kick off. We'll do sort of just a refresher on the purpose and rationale behind the performance guarantees. We're going to spend a little bit more detailed time in today's presentation talking specifically about the financial trend guarantee that's proposed. We've truly, in a team effort, gotten input and collaboration from the experts at Mercer and Willis Towers Watson, as well as staff internally, and have fleshed out some more specific details around the financial trend guarantee. So we'll walk through that. And to note, we do still anticipate some back and forth with carriers on review and comment of what we've outlined. And then in addition to spending a little bit more time in depth on the trend rate guarantee, we'll talk a little bit more about what we're planning for transparency reporting, and then also update on the other guarantee negotiations in process for clinical quality, administrative measures, clinical management, and account management. So with that all said, I believe Michael is going to start us off with today's slides. So I will hand it over to him for starters.
Sure. Thanks, Margaret. So you go to the next slide. So this is just a reminder, the guiding principles that we talked about last month. So we want them clearly defined with benchmarks if they're available, critical to monitor the financial performance of the plan. Obviously, you want to have fulfill your fiduciary responsibilities, nationally recognized if possible, relevant to your populations, impactful to the member experience, applicable to the performance requirements of the benefit partner. So they have certain functions that they need to perform, and that'll come up in the administrative and operational metrics as well as the clinical management metrics. Balanced reporting of the actionable outcome focused measures and the administrative burden. In other words, how meaningful is it and how difficult it is to capture that data. And align as appropriate with other OHA efforts regarding health system improvement statewide. So this is just a reminder that we talked about this before. And so in using benchmarks and goals, we use national benchmarks when they're available and appropriate to the type of plan. This is going to come up in Margaret's section on the clinical quality. Evolve and modify the PGs and their benchmarks over time based on their performance. So it may be that you raise the bar. It may be that you, the next column there is retire metrics that let's say the plans and the providers have achieved those metrics. So you can move on to another topic. Also, the field of quality metrics particularly is rapidly evolving, and they come and go. Some get retired by NCQA or the National Quality Forum. Others come into play their new metrics, and we just spent some time talking about social determinants of health. We may in the next year or so have relevant metrics related to social determinants of health and health equity. And the other guiding principle is to increase the amount of performance guarantees at risk over time to provide incentives for ongoing performance improvements. So these were all showed before, but since it's been a month, this is just meant to be a refresher on what these guiding principles are. Next slide. So in terms of where we're at today, we, per your feedback last month, have solicited feedback from the carriers regarding the metrics, and we've made adjustments to the metrics based on this feedback. We're continuing to have ongoing dialogue with carriers regarding the specifications and the benchmarks for metrics. This will come up during the different categories of metrics. The carriers have agreed in concept with 15% of administrative fees at risk spread evenly over the 3 categories of PG metrics, including clinical quality, administrative, operational, and financial trend. We are on track with the progress with those performance guarantees, and we're hoping to get this finalized in the next few months, to have the PGs, the benchmarks, all that signed, sealed, and delivered in the next few months. On the next slide. So just as a reminder, there's 6 categories of metrics. The administrative, operational, financial, trend, and clinical quality, which are the ones with fees at risk. The fees at risk, as I mentioned, is 15% in total of the administrative fees, and it's split evenly 5% for each of the 3 categories. The other 3 categories below, fees are not at risk, and they are on a report-only basis for 2022. That could change down the road, depending on what kind of performance we see with these. And on the next slide. So at this point, I'm going to turn it over to Emery.
Thanks, Michael.
Sure.
The slide is the first of a few talking about the proposed trend rate guarantee for the plans. Generally, it's going to be a total cost of care, which tries to, with the threshold at about if the costs increase at 3.4% or less. So if the plan's cost increases less 3.4% or less, there would not be a penalty. But if it does increase by more than 3.4%, there's basically 2 levels of penalties that potentially could apply. The first is between 3.4% and 4%. Then if it costs increase between in that range, then there would be a 2.5% administrative fee penalty that would apply. And if costs increase by over 4%, a penalty of about 5% of administrative fees would apply in this case. About to go into some details on the additional details on the trend guarantee. We would calculate it separately for each plan that contracts with Pebb and OEB. For Pebb, this would mean that, for example, Providence Choice and Statewide would be considered separate plans, and the rate trend rate guarantee would be calculated separately for those 2 plans. We're proposing for OEB that it would be for 2 plans, Kaiser and Moda in total. And just to note that the plan years would be essentially the plan years for each plan. So for OEB, it'd be on an October to September basis, and for Pebb, it'd be on a calendar year basis. Moving on to the next slide. Some additional details. What we would do is we would set a prior year benchmark. So that would be a per member per month cost based on essentially the prior year allowed charges. Initial prior year in this case would be 2021, so OEB would be October 2020 through September 2021, and Pebb would be the January 2021 through the end of this year. All essentially coverages, all benefits would be included from the medical plan. So that would be medical, prescription drugs, mental health, substance abuse, and fertility, among others. It's not limited just to those, but we just want to show examples of what would be included. We would offset potentially with rebates for pharmacy and medical pharmacy rebates. Those would be not considered costs if they are actually credited back to OEB and Pebb. But if any pharmacy or medical rebates are being retained by the carriers and not actually credited back to Pebb, those would be excluded from the calculation and not be applied to the allowed charges in this case. All populations would be included, so active COBRA retirees, and we're anticipating using 6 months of runout for the claims. So it would essentially, for Pebb, calendar year plus 6 months. So claims run out through June of 2022 in this case, and so OEB would be 2 months earlier.
Question.
Yes.
How does what potential is there for unintended consequences of rationing care under this type of trend rate guarantee?
In terms of rationing care,
well,
are you talking about
excessive denials or things to stay under the budget?
Oh.
So denied care.
I'm
just wondering, I'm being devil's advocate here. What's the potential for this to bite us in the hindsight?
Well, I mean, I guess there could be a potential where they would look more closely at their utilization management. But if there are appeals because they're unnecessarily denying care, that is an added cost. I mean, I don't think the plans would necessarily want to anger OEB or Pebb
Sure.
by being unnecessarily strict. Correct.
Hey, Emery, this is Michael. So a couple of things. You'll see, Jeff, in a couple of other categories of metrics, we've actually asked questions around appeals. We've asked questions around timeliness of utilization management reviews to get at that very issue about is it resulting in poor member experience?
Okay. I'll sit on my hands for a couple more slides.
To your very point. No, it's a really good question. And that's why there has to be these balancing metrics out there of looking at the full scope of not just the cost part, but the member experience and quality. Also, it's in the clinical quality with the CAP scores, which is the consumer satisfaction with the health plan. So there's other ways that we can get at that data.
Okay.
Jeff, one last thing from James. The size of the penalties is not worth getting in trouble. It's worth doing a good job. It's worth trying to meet it, but the size of the penalties is unlikely to be something that you're going to compromise your reputation and your other metric scores for.
Yeah, it's applied against the administrative cost, and most they can lose is 1%, basically.
Right.
Yeah.
Just to follow up on that and be a little more direct with Jeff's question. So in particular, I'm thinking about mental health and substance abuse.
Yeah.
So mental health and substance abuse right now is not enough, right? We're probably not spending enough on it because there's not enough providers for enough people to be going to it enough of the time to actually meet the need. So that would be one area where there could accidentally be a perverse incentive to sort of further drag one's feet, so to speak, on beefing up access to mental health, just because it's going to raise your costs. And I still really like this, as you know, this financial incentive. It's just something to keep our eyes on, because on some level we are expecting mental health and substance abuse treatment to increase to some degree over the next few years, we hope.
Yeah.
Because we want people to use it more than they are now, which is not enough.
Right. And Sean, I actually had a large client that we purposely worked with them to increase outpatient utilization. And what happened was the overall behavioral cost trend went down, even though outpatient service utilization and costs went up significantly, but inpatient care went down. And emergency department visits for behavioral health purposes went down. So, I totally agree that we want increase in behavioral health, but I think you have to look at what level of care. Because one is patient, you don't want the inpatient, you don't want residential, because in some ways that's a failure to get early intervention. So anyway,
good point. That's a good point. Okay, I'm done. But great point, and it was a good question. So just something to keep our eye on. Good, thanks.
Okay. So we would also potentially include a large claim threshold. So any amount, allowed amount above the $500,000 threshold would be removed from the prior year benchmark. And
that also makes sense to me, right? Because I know I've been in those meetings where you end up having, what is it, the hemophilia person, and it's like $8 million, and it's like everything you've done over the previous year. That happens, and it's not a prevention thing; it just happens.
Yeah, I agree.
Yep. And what we would also do would be to remove any eliminated benefits from the prior year benchmark. And what is meant by this is if there were plan design changes that essentially took away a benefit from the member. So going back to when bunionectomies, I guess, were removed from the Pebb plan a while ago. So if bunionectomies were no longer being covered, then the costs for those services would be removed from the prior year benchmark, just so because it's not going to be a continuing service in the future year plan. So that's so that's some details on it, at least for creating the prior year benchmark. And then on the next slide, we would be comparing that prior year benchmark to the performance year actual. So that's based on the measurement year using the same data specifications as the prior year benchmark. So all of those elements in terms of the large claims threshold, what's included would be carried forward using 6 months of run out. One change would be new benefits from plan changes. So if increased infertility benefits or massage therapies were added, those would be removed from the performance year actual allowed cost. So you wouldn't have an increased cost that was essentially elected to by the boards to increase the benefits of the plan. So the plans are not essentially held responsible for what the boards have chosen in this case. And then for the initial measurement year, just showing there, it would be essentially the following year, so October 21 through September 22 for OEB, and then calendar year 22 for Pebb. And just to kind of restate the increase, the trend guarantee, if the change is less than 3.4%, 3.4% or less, then there's no penalty. Between 3.4 and 4, and then this 2.5% penalty would apply. And then if the change from the benchmark to the actual is more than 4%, then the 5% penalty would apply in this case. Any questions? Okay, moving on. There is a little bit of detail here about risk adjustment. One area of concern, and these details, these are our proposals. I think the plans have will probably have some responses to it, and so we may do some revisions on it and some back and forth. But this is our current proposal for potentially adjusting for population changes from the benchmark plan year benchmark to the performance year actual. So for the continuing members, continuing population members, so those who are enrolled at any point during the prior year in the measurement year, so the benchmark and the actual year, those are continuing members. We would not adjust those members. Those are the members that the plans would essentially be managing from year to year. So you would be hoping the plans would be able to manage the risk lower as well as the utilization and costs in that case to meet the 3.4%. For those members who left the plan during the prior year, benchmark year, or enter the plan during the measurement year, we would be trying to adjust for the potential risk of differences of those members. So those members who left would be those who were enrolled in the plan during the prior year, but not actually in the plan during the measurement year. So their claims would be in the prior year benchmark, but did not have claims incurred in the performance year. And then joining members are essentially the opposite, those who weren't in the prior year, but actually are in the measurement year. And joining members, just to, as a note, those could include new entities that joined OEB and Pebb. Essentially, what we would do would be to normalize the per member per month costs for those members who were either leaving or joining to match the risk of the continuing members. So any differences in risk due to those for those members would essentially be normalized out. So if you had somehow a very expensive new members joining, we would be bringing down the cost of those and the risk of those members to make it much more level, closer to where the continuing members are in this case. And then we would then weight their costs by member months to essentially just come up with the overall average per member per month cost in this case. Any questions? Moving on to the next slide. Some additional details. Just since we do have risk scores and we have the claims for the members in the IBM Watson database for both OEB and Pebb, we're proposing using the DCG risk adjustment methodology that's currently in that database. We would then have to, the guarantee would be calculated in the month following the availability of the 6 months of runout claims for that in the database, so we can have the complete claims and complete risk score changes for those populations. We would not do exclusions or exceptions for new medical technology, so new specialty pharmacy drugs or procedures would be included in the allowed claims. It's, you know, those happen. It's part of the costs. Pebb and OEB are held responsible for those costs, and so therefore we propose that should be part of the trend rate guarantee in this case. This last section, you know, potential additional discussion about what would happen in case of a pandemic. It's, you know, in terms of the full-on details, I don't think we have them completely fleshed out. There is a proposal here that if the claims for this initial prior benchmark might be artificially low due to maybe services being held back during, you know, the beginning part of 2021, where the COVID cases were increasing in Oregon. If that has an undue influence on the actual allowed cost, then we may want to adjust the time period that we're talking about. And one potential proposal would be to use an older time period for your benchmark and then trend over 3 years in this case versus trending over just the one year 3.4% increase threshold. So that's something that's up for discussion with the plans. You know, it's potentially up for discussion, I guess, with the IWG. So if you had any thoughts about it, we'd want to hear. But one other final point before opening it up: there would not be any credits earned from essentially achieving this trend rate guarantee. So this one would stand on its own, and if you achieve it, then there's no penalty, but you cannot offset penalties from other performance guarantees for achieving the 3.4% cost growth target in this case.
This is Tom. So the if you moved it back to the pre-pandemic year for your base year, and then you're looking 2 years ahead, would it be 3.4 times 2 because you basically have had 2 years of trend, or are you still looking at only the 3.4?
Yeah, so it would be an annual trend.
Got it. So you'd multiply it by 2.
Yeah, we would.
Yeah.
Essentially. Yeah, it would be an annualized trend rate increase.
Yeah, good. Yeah, annualized trend. That makes sense.
And I think that's actually the last slide on the trend rate guarantee. So we can turn it over for the clinical quality metrics.
Great, thank you, Emery. Okay, so on to slide 11. I'll give a quick update on where things stand with the clinical quality metrics. As you can see in this list, it should look very familiar. We proposed 17 specific metrics as part of the clinical quality metric performance guarantee for Pebb and OEB. We have received comments from carriers related to the proposal, and we're currently working through carrier feedback along with staff and Mercer, reviewing information received and examining where we want to refine the proposal. You can see on this slide we flagged several measures that we're indicating are under review, and essentially that means we're still sort of working through comments and assessing where to go next. And there are different reasons for why a measure may be under review. For example, the childhood immunization status combo 2 measure. My understanding is that NCQA is changing the specifications and actually removing the combination 2 submeasure. And this is the one that is approved by the Health Plan Quality Metrics Committee on the statewide aligned measures menu. So My understanding is HPQMC is taking another look at this measure to identify what rate it will include on the aligned measures menu. And once that determination is made, we'll align the measure that we require for Pebb and OEB carriers with the decision that the Health Plan Quality Metrics Committee makes. Some of the other measures, follow up after hospitalization for mental illness. There are a couple of different sub-measures, both a 7-day and a 30-day measure. We're taking a look at comments from carriers and making some kind of final determinations about how to finalize the proposal with regard to that. Similarly, for plan all-cause readmissions, we're looking just in more detail at comments that carriers have provided and refining. I do want to note that sort of across the board, we're, to the fullest extent possible, we're really trying to align with measures that NCQA requires for accreditation, to the degree that we're able to, just to sort of align the reporting carriers are already doing and hopefully be cognizant of administrative burden. The other aspect of the clinical quality metrics that we're still working on is related to scoring. And we've noted previously that we expect to use the 2/3, 75th, and 90th HEDIS national percentiles for commercial plans and come up with a scoring structure where we award different point levels to carriers based on them achieving with points allocated increasing as carriers reach higher percentiles. One aspect of this scoring that we do want to incorporate is to acknowledge the expectation that coordinated care model plans should demonstrate enhanced quality when compared to PPOs. And so there are a couple of different ways you can do that, either through one option being looking at using different HEDIS percentiles for CCM plans versus PPO plans. Another approach being to use the HEDIS commercial PPO percentiles for both types of plans, but have the scoring structured so that there's an expectation that either the target set for coordinated care model plans would have an enhanced quality expectation above the PPOs, or that the number of targets that a carrier would have to hit for their coordinated care model plans would be set at a higher level, an expected higher level than the standard traditional PPO. So right now we're working through, as noted, carrier comments and just the different options for how to approach the benchmarking and scoring. And I expect that within the next month or so, we will have have a lot of that fleshed out and be much closer to final in terms of where we anticipate this being set for final contracting for next plan year. So are there any questions about status for clinical quality measures? I do want to note and thank the carriers. They've been very engaged and we've received a lot of comments and thoughts, and so it's been a collaborative process of back and forth in terms of understanding kind of their perspective and insight into some of the measures and considering that as we refine our proposal. And if there are no questions, we can move to the next slide. The second, or I should say third and final category where we have fees at risk assigned is the administrative and operational measures. This is a collection of a dozen measures we've proposed for carriers. You can see on the slide, we have our recommended performance targets, and we've also flagged the specific measures where we're still doing some additional review based on comments we've received from carriers. I also want to note the bold pink font on this slide just flags where we have made some refinements to the original proposal based on feedback received from carriers, particularly where we may have, generally speaking, with these three measures highlighted, we've made some slight adjustments to the expected performance target based on some of the dialogue back and forth. So are there any questions about these measures currently?
This is Tom. Margaret, going back actually to the CAPS ones from the quality measures, those are all, that's all planned. That's not specific to OEB and Pebb. correct?
Yes.
Yeah,
That
fine.
is correct. So so for the CAPS measures, those would be commercial book rates.
Got it. That's good.
Being reported.
Yeah, thank you.
Great. And if there are no questions about anything else related to clinical quality or administrative and operational, we can move ahead to the next slide. And transparency reporting. And Emery, is this back to you or James?
It is back to me, although I will ask for some color commentary from James as he wants to interrupt. So for transparency reporting, there are no fees at risk, but they are, reporting requirements to try to shine a light on value-based payments, reimbursement levels. And, we have, those were reports they had provided in the past, but I guess this is more formalized request to continue those on an ongoing basis. But we also want to maybe take a look at, unit cost increases and payment variability across sites of service and build off of reporting that, is going to be required of the plans due to the new federal transparency and coverage regulations that are scheduled to take effect for next year. And we will go into detail on the following page. So while we're talking about the reports, outlines of the reports here, the details are being finalized, and we will ask the carriers for their review and comment. And James, if you want to interrupt, feel free at any time. Moving on to slide 14. The transparency and coverage regulations. This is a very shortened version of them. They are pretty long, but the final regulations were released on November 12th, 2020, requiring most plans to disclose price and cost sharing information starting next year. They do not apply to grandfathered plans, HRAs, or other limited scope plans in this case, but essentially would be for Pebb. For cost information would be available in two different ways. One would be by posting machine readable files with pricing information on publicly accessible internet site and must be available for plan years starting after January 2022. And we would want to build off of that file for some of this reporting. Another way that reporting has to be available via the regulations would be by providing a self-service tool for enrollees to obtain personalized out-of-pocket cost estimates. There's 500 services that start in 2023, and then it expands to all covered services starting in 2024. On the following page, are the requested reporting. So the first page here has two reports that are essentially reports that have been provided previously. The first is the value-based payment reporting, and in this we would ask the plans for each land category, by 2B, 3C, 4, to report total amounts paid, total amounts at risk, and total amounts earned. They would also report the number of contracts and providers covered under each arrangement, as well as the quality metrics applied to the provider. So there might be a little bit more detail than what was provided before, but essentially would be continuing some of the breakouts of the value-based payments by the land category reporting that was done previously. The second requested reporting that has been seen before is the percentage of Medicare. So similar to the cost analysis done for the 200% Medicare pricing analysis, and also some of the IWG costs as percentage of Medicare by cost different categories. We would essentially ask them to keep doing that on an ongoing basis. So categories of service would include inpatient, outpatient facility, specialty drugs, PCPs, etc. We would also want to do some sort of cost reporting in terms of benchmarking pricing for prescription drugs against a standard in this case. That's something that we didn't do before. We haven't decided on the exact standard. I think there's a few out there, but we would want to include this to expand it to prescription drugs.
So, point of curiosity, while there's no fees at risk, is there an additional charge to provide this reporting?
I would hope not, as I don't believe we were charged for it originally. So,
Okay.
yeah.
All right.
I think. Okay. Page 16. So these two are kind of new requested reporting, and these are essentially builds off of the machine readable files that would be required in the transparency and coverage requirement. So what we would do would essentially request versions of those machine readable files for Pebb and OEB. And we would also want to have it include the prior year's costs. So there would be 2 years of costs by the facility provider and service that we could then use to determine what would be an overall unit cost increase from 1 year to the next. We would also ask that the number of services be populated for each of those providers and services, and therefore we could, come up with an overall cost, and then maybe based on weighted average change from 1 year to next. So we would have the prior year's services or the current year's during the prior year services times their prior year allowed costs, and then we could compare that overall cost per service by whichever various categories to compare that against the services from the prior year multiplied by the current year's cost. So in that way we could see what the unit cost increases, actually drill down to the unit cost increases for each for Pebb and OEB in this case. The other reporting we would try to do would be the payment variability reporting. So since we would have these machine readable files with the different providers and the allowed cost by services, we could use that to illustrate essentially the average allowed and also break out the percentiles, minimum, maximum, using the data from that file. We could compare it based on types of services and also potential locations to try to illustrate where there might be cost differences due to site of services, regions, whatnot. But this would be based off of the machine readable files and what for the allowed cost number of services. So we could just do a comparison of the cost variability in this case. There is one other element that wouldn't necessarily be in the machine readable file. So we would want to also take a look, ask the plans to provide the top 15 episodes of service by patients and also top 15 by total dollars. So episodes of care service. So, this may be like a knee surgery or stent replacement or whatever the top 15 cost services. I think maternity may be, C-sections and deliveries may be one of those, but be able to get that information as well to take a look at the average allowed, the percentiles and minimums, maximums to kind of show what the payment variability would be for those top episodes of care.
And I'll only add one thing, Emery, in case Sean is looking and wondering what happened to site neutral payment. We were trying to leverage what's already happening in transparency and keep our original plans intact. So we might need a little more time to look at those services that are already being machine readable files and see if there's a cross map to some of the site neutral services that we want to make sure that we understand the range of variability in the payments.
This will be really helpful for figuring out how, if we expand reference pricing for other surgical procedures and the like. And also, I'm amazed by Jeff in inventing a new Robert's Rules of Order. Point of curiosity. I love that.
What can I say?
It's perfect.
Okay. Any other questions or comments? Turn it over for the account management PGs.
Thanks, Henry. So you can go to the next slide. Yeah. So for the account management PGs, we actually changed all of the things that we were going to measure based on feedback from the carriers. It was very helpful feedback. And I think the important point here is that we would want a mix of OHA staff members, leaders, as well as board members completing the account management survey. We're thinking of it as a once a year exercise. And the details of exactly who would be completing the account management survey have yet to be determined. But I think it's best practice to have the board and the OHA staff. And if there are others that you would want to complete the survey, that's of course up to the board. You can go to the next slide. And the clinical management program, so these are metrics based on the clinical management programs that are offered by the health plan. So this is utilization management, catastrophic or complex case management, disease management that are offered by the plan administrator. These are not from the healthcare providers directly. And so it's a mix of member satisfaction with those services. What percentage of the overall population was there some kind of interaction or communication with that with those members overall? What percentage of the high cost claimants were engaged in the care management at the plan administrator level? That's really important in terms of understanding the management of costs. And then the utilization management timeliness. So it's a mix of member satisfaction, overall population health management, engagement with high cost claimants to reflect a good cost management techniques. And utilization management is basically timeliness is to ensure that we don't have member abrasion.
Yeah.
This is Tom. My only question has to do with the case management percentage. That is a health plan activity that is sometimes it is necessarily only because oftentimes delivery systems don't own that. There are delivery systems that are increasingly owning that. So there needs to be some way to acknowledge where the delivery system has taken on that, where there is not the need for this add-on supplemental health plan activity.
Right, it's the next slide, Rose. Right, so that would be a delegated function. If you've got a plan that's accredited, Tom, right, and they're delegating that function, they need to do that explicitly, and that would be included as a part of the percentage of the high cost claimants that are being managed.
Great.
Yep. Yep. I would say my experience is that is a little more difficult for some health systems to do. It's a pretty sophisticated health system to manage those high cost claimants, but as long as someone is, whether it's the plan or they've delegated to a health system, I'm fine with that. I think that's it for me.
Okay, thank you.
Yep.
So work on these performance guarantees, as was mentioned, is will continue. I anticipate we'll have perhaps another briefer update at the June meeting about status, but we will certainly keep the work group and board informed as these move forward.
Right, thank you, Margaret. Question goes to Rose. Public comment?
No public comment.
Okay. Well, that allows us to finish on the dot at 4 o'clock. Take one more breath. Thank you all. A lot of content today. Really appreciate it.
Yeah. Thanks everyone for your work.
You run a tight meeting, Jeff.
Oh yeah.
Thank you.
Thanks anyway. All right, we'll talk. Take care.
Bye-bye.
Bye now.
Bye. Thanks, everyone. Rose, this is Margaret. I will stay on if you want to do a little technical caucus here.
Sure.
Yeah.
How about if I just try this right now?
Yeah. I was going to say, and if you want, I can, oh,
Because
are you?
mine doesn't show any option for me to share.
Mm-hmm. So if you share your screen and
Okay.
project, you know, a presentation. Okay.
Okay. Hold on.
Okay. So it
All right.
says,
So I'm sharing the screen.
okay, and it doesn't have any icon. See, I have this button that says request control. So I can, and it says, and so I can send you a request. And it says my request, that's weird. It says my request for control was not accepted.
Yeah.
But I'm not seeing your shared content anymore either.
Yeah, because see, when I push on that, it just goes away.
Really?
And oh, now it says share. Wait. Okay. Let me share the screen again.
Okay.
Now, do you see it?
I do, and I see the screen, and so if I hit request control, it says you'll request control. You'll control the content the presenter is sharing. So I click request, and it should send you a message to give me control.
Yeah.
Are you seeing anything? Because I see on the screen it says that I'm requesting control, and the options are allow or deny. Do you see that on your screen?
Am I supposed to get this in Teams, in chat?
It's in Teams. Like I'm looking at the presentation, your shared screen, and what I see, and now it says you didn't get control again. Your request for control was not accepted. So hang on.
Yeah.
I'm gonna hit it again.
Because I don't know where I'm supposed to look for it.
Okay, so it should be in Teams. It should all be within Teams. And if you look, like I'm looking at the screen and I can see this little pop-up that says I'm requesting control.
Oh, wait a minute. Hold on. Okay.
And so then if you
So
hit
it pops up.
allow, okay. And so
Okay, but how
now
come I can't do that?
I don't know. And so do you see my icons on there now? Like I see my
Yep.
icons on there, and I wonder, and if I do, let me see, page up. It doesn't look like it's how, let's see. Oh, it looks like I can maybe.
It's moving. I mean, I can see it.
Yeah.
I can see it moving.
Okay. So it's weird because I'm just trying to figure out. So it's letting me use my, okay. So now it's letting me, it seemed like maybe it just took a minute, but like if I hit page up or page down or use my mouse, it is now letting me to toggle through, it's letting me toggle through the slides.
Okay.
And then I have this,
yeah. Seems like when we first started doing this, and it was probably an OEB meeting, I tried to give control to Sapari.
Uh-huh.
So I had it then, but now I don't even know where to look for it.
Yeah. Well, and so now, and it's interesting because it's right at the top of my screen. And so I can hit stop control and it looks like